Good morning. My name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for the MAVEN Project. And thank you all for joining us today. And thanks to our friends at Generations Family Health Center in Connecticut for requesting today's session, Pediatric Voiding Dysfunction with Dr. Adrienne Carmack. Dr. Carmack is a Director of Medical Affairs at BD, Becton Dickinson and Company, a large medical device manufacturer. She is a board-certified urologist with over 15 years of clinical experience. She is also trained in integrative, functional, and holistic medicine. Her passions include preventive medicine and patient empowerment. Dr. Carmack's areas of expertise include bladder and prostate cancer diagnosis and prevention, overactive bladder, pediatric voiding dysfunction, and other disorders of the kidneys. Welcome today, and I'll turn it over to you. Thanks so much.
Okay, thank you so much, Jill. So I'm happy to be speaking with you all today about pediatric voiding dysfunction. I know this is probably something that you see frequently, and it genuinely can be a real opportunity to have a major impact in someone's health for the rest of their lives. So I'm looking forward to sharing why that may be the case with you. I do work for BD, as mentioned. I won't be speaking about any devices that BD manufactures today. So our learning objectives today are learning how to classify the issues of voiding dysfunction in children, understanding common comorbidities, diagnostic criteria, and practical management, and being able to determine when to refer. So about me, I am board certified since 2011. I went to medical school at Texas A&M and did my urology residency in Miami. I've been working for BD since 2020. And soon after I started working at BD, I began volunteering at a clinic in my own community. Bethesda Health Clinic serves the under and uninsured. And I go there one day a month to provide urology consults. I live in Longview, Texas. This is in the East Texas Piney Woods. And most importantly, I'm the mother of 3 children, all of whom I have successfully trained to urinate at appropriate times and in appropriate places. Which I think gives me more expertise about this than even being a urologist. So the scope today, we're going to talk about a lot of things, and hopefully it's not overwhelming, but genuinely informative and will be helpful in the future. We'll speak about voiding dysfunction in children. We'll talk about bladder and bowel dysfunction, lower urinary tract dysfunction, overactivity, daytime incontinence, enuresis, and dysfunctional voiding. Go through all the definitions, diagnostic criteria, practical management, including lifestyle management, and red flags and when to refer. And I will speak a little bit about some of the common comorbidities of UTI, vesicoureteral reflux, neuropsychiatric issues, neurologic issues, and abuse. So before we start, I just want you to be thinking about the types of voiding dysfunction you might be seeing commonly in your practice. So here's a sample case. A 6-year-old female, no past medical history. She comes in with the chief complaint of having accidents at school. So I'd really like for you to take a moment and just think about what your differential diagnosis is. And if people would just type in the chat what they're immediately wondering might be going on and that they might be thinking of asking about or checking during the visit. And I'm just going to pause and wait till we have at least 3 and then I'll proceed. And Jill, I don't think I can see the chat. Oh, maybe I could bring it up.
Great. Let me just see. I may have to activate so people can chat. I'm nothing in the chat yet.
Oh, okay. No one can chat. Okay, I'll move on, but feel free to type differential diagnoses in there if you think of them. And then case 2, 11-year-old male, no past medical history, comes in with a complaint of bedwetting at least 4 nights a week. So same thing. Already just you see this on your appointment schedule, bedwetting, accidents at school, and the things that you're thinking about. I will come back to these cases at the end of the talk and tell you more details about these situations. So terminology and definitions. So these I pulled out of the International Children's Continence Society, which is one of the societies that has aimed to define these things. These are pretty standard definitions that would be understood. So bladder and bowel dysfunction means having both bowel and bladder disturbances. Lower urinary tract dysfunction is specific to issues in urinary storage, emptying, or both. And just as a reminder, the bladder these are the two main functions of the bladder: storage and emptying. And so the bladder, this is normal function. The bladder should fill, you should have the desire to void, then you should have time to be able to make a decision to void. So that's filling and storage. Then you decide to void and you empty, and symptoms in that phase are emptying phase, and then the filling cycle begins again. Bowel dysfunction is similar: disturbance of the GI tract in storage or elimination of stool. And the most common bowel dysfunction that we'll see in pediatrics is constipation and encopresis. So storage symptoms, this is the bladder should be able to fill comfortably. You should feel an urge to void, and then you should be able to have time to choose when you want to void. And all of the things listed here are symptoms that indicate a problem with that phase of bladder function. So frequency is defined as voiding more than 8 times a day. Normal should be at least 3 times a day. So 3 to 8. Urinary incontinence is any involuntary leakage of urine. Continuous is when the urine's constantly leaking. This is usually due to congenital malformations like an ectopic ureter, where the ureter inserts distal to the sphincter, so there's no control of the urine output. Loss of sphincter function, which can happen for a variety of reasons, or iatrogenic, especially in older women who have had gynecologic procedures or traumatic childbirth. We may see vesicovaginal fistula, for example, as a cause of this. This can also happen in children, but it would be after surgery, typically, when they would have this reconstructive surgery. Intermittent incontinence is obviously leakage that occurs at varying times. And if it occurs while they're awake, it's called daytime incontinence. If it occurs while asleep, it's enuresis. Urgency is sudden and unexpected experience of an immediate and compelling need to void. So it's not you drink a Starbucks and then you suddenly have to go to the bathroom. That's normal. That's not unexpected. It's a hallmark of bladder overactivity, but it's not the same. Overactive bladder is not having urinary urgency. Overactive bladder is a disease for which a symptom is urinary urgency, but other diseases can also cause urgency, like UTIs or bladder stones. And incidentally, I don't talk about this more here, but bladder stones, they don't happen routinely in children in the United States, but I did do a medical mission trip in India, and it was extremely common to see bladder stones in children there. Nocturia is awakening at night to void, not having accidents, but needing to wake up and go to the restroom, different than enuresis. Okay, so we were on other symptoms. So some other symptoms that you may have children know: holding maneuvers is one. These are behavioral strategies that children do to postpone voiding or suppress urgency. So this might be standing on their tiptoes, crossing their legs really strongly, grabbing or pushing on their genitals or their abdomen, sitting on the edge of a chair and putting pressure on their perineum. These are all mechanisms that actually inhibit spinal signals, efferent nervous signals to the bladder. And so caregivers might not realize that they're attempts to interfere with voiding, but they might have noticed the behavior. So if you're aware of them and you ask about them, you might find out the child's doing these to postpone voiding. And then incomplete emptying, urinary retention, these can be real things or things that someone just feels: spraying or splitting of the urinary stream where it doesn't come out in a straight flow. And then pain and itching may also be symptoms that are seen with voiding dysfunction or constipation. And finally, leaking urine after voiding. So this is seen in girls who have vaginal reflux. It can be seen in boys who have syringocele. And this is not common, but this is just to illustrate why someone would have post-micturition dribbling. So it's because urine gets trapped somewhere distal to the sphincter. And so then they may close their sphincter, but there's still urine that didn't come out of the urethra, and it'll come out as they get up and move about. This is also common in men with enlarged prostates, where urine may get trapped within the prostate and then leak out later. So evaluation, history, just like with everything we do, is super important. You really want to characterize their symptoms. You want to find out about their potty training, when this happens, and exactly what's happening, using some of the definitions we just talked about to help guide your questions, like how's the stream, when are the accidents happening, how frequently are they going, do they have urgency, etc. Oh, I'm sorry, advanced. You always want to evaluate for red flags, and you want to be thinking about comorbidities and social stressors that may be interfering. One tool that is extremely helpful in the history is a voiding diary. These are basically charts that the family would use to record voiding patterns. You can find several of these online. You could easily just make your own, which is what I always did. And you can make these very easy. Like you might just want them to write down which nights they wet the bed, or you may want to know how much fluid they're drinking every single time they void, figure out their total bladder volume and bladder capacity with calculating and adding things up. You can do whatever you want. And if there's something that you think might be making it worse, like say drinking soda or something, you could have them mark when they drink soda, the days they do and the days they don't, and compare. You can really use this as a valuable tool for understanding better what's happening when it's hard to understand from just the history, and also to help the patient with awareness. If you want to know what's really happening over 24 hours, you need to start, you have them get up in the morning and void. And then after that time, they start recording all of the urine that they produce. That's how you get an accurate 24-hour urine output. And so if they void at 6:55 a.m., starting at 6:56 a.m., you're going to record every void that they have. And then at 6:56 a.m. the next day, they'll empty their bladder, even if they don't feel like they need to go. So you can see what they've made up to that point. You always want to do a voiding diary for at least 2 days. And if they are really discordant, you'd want to do more. And you might want to do them for as long as a week, depending on what you're trying to ascertain. Bowel function is very important to ask about in the history. This is probably the easiest way to assess for constipation, because a lot of people, if you ask them if they're constipated, if they're going every day but having type 1 bowel movements, they might say no. What's considered normal is 1 to 3 snake-like bowel movements a day. Ideally, type 4, type 3s and 5s can be all right. You can include this in a voiding diary. I always did. I would, in addition to having them record when they urinated, I wanted to know when they had a bowel movement, and just would have them write what type it was on the Bristol scale, which gave me a lot more insight than asking questions often did. If a child reports incapricis or incontinence, they do need a GI referral, as an aside. Asking about diet is super important. There are many lists online of common bladder irritants, so it's a good starting place. I might show a patient this list and say, are there any foods on this list that you're consuming regularly or more than other people? There are certain things that tend to be issues for a lot of people, like lemonade, sodas, juices, certainly alcohol and caffeine, although we don't see those so often in children. You can also ask if there's something the child loves or is consuming frequently. I had a child like this. She was having a lot of urinary frequency and also diarrhea, which made me suspicious that it might be something she was eating that was causing irritation. And I asked this question, if there's anything that she ate a lot of, and our family told me she loved spicy salsa and that she could out-eat everyone in the family with spicy salsa. And I was like, well, why don't we just try cutting that out for a couple of weeks and see what happens? And that resolved her issues. And so then they knew, didn't mean she couldn't ever eat spicy salsa again, but it meant if she did, she needed to expect that her bowels and bladder would respond unfavorably. And this is something you could also put into a voiding diary. If there's something you suspect, they can write it down and see the effects it has. Physical and sexual abuse need to always be considered a possibility when you're seeing a child with bowel or bladder dysfunction or recurrent UTIs. You can simply ask the parents if they're aware of or concerned about any possible experience of abuse. You can observe or ask the child as is appropriate. Most importantly, too, is to make sure that the child and their parents know they can tell you if they have any concerns. And of course, you need to follow whatever the laws are in your state for reporting suspicion. In Texas, we are required to report suspicion of child abuse to CPS. Physical exam. So you do need to do a genital exam when a child first presents with urinary symptoms or if they've had a significant change in their condition. But that genital exam does not need to be invasive or traumatic in any way. So you certainly want to inspect the external genitalia. You want to look for rashes, signs of trauma. You want to look at their meatus, and that you want to do that gently. So you can very gently spread the labia to see the meatus. You can very gently retract the foreskin to see the meatus. You should not do anything with force, tearing the foreskin back, or certainly not forcing the labia open. But if you see any issues, then those could be related to the urologic dysfunction, and they might need a referral. You also want to look at the lower back, sacral dimples, hair tufts, skin pigmentation. All of those can be signs of neurologic dysfunction that could cause bowel and bladder issues. You want to check their flank for costovertebral ankle tenderness, especially if UTI is a suspicion. Check the abdomen and pay particular attention to fullness, constipation, and any suprapubic tenderness. Labs, you should always check a urinalysis with anyone who's presenting with urinary symptoms. This lets you evaluate for possible diabetes mellitus or insipidus, hematuria, proteinuria, infection. If UTI is suspected, you want to do a urine culture. And some of the latest guidelines actually suggest that the urine culture should not be based on the urinalysis results. It should be based on symptoms. Urinalysis does not correlate well with positive urine cultures, but acute onset of symptoms such as dysuria or suprapubic pain does correlate well, and those would prompt a urine culture. Certainly, if there's an abnormality that suggests UTI, you would also do, on the urinalysis, you would also do a culture. Pelvic ultrasound can be used. This is non-invasive, so it's safe to do, but it certainly can be expensive. It's very nice to be able to check a post-void residual, and most urology clinics have a portable handheld bladder scanner with which they can do this. If you don't have access to this and really do need to know if the child's emptying or their bladder or not, you can order a regular ultrasound and ask for a post-void residual, and they will do that for you. VCUGs, Lasix renograms, KUBs, and more invasive tests are all options, but those would all need to be ordered by a urologist. If you think they might need those, then I would definitely refer them for further evaluation to urology. So diagnoses. So how you make your diagnosis depends on all those factors that you've just asked about and how you're classifying their symptoms. So overactive bladder is defined as urgency without a UTI or other pathology, such as a stone, causing it. It's usually frequency, often nocturia, and may or may not include incontinence. Voiding postponement. So this is habitual postponement using holding maneuvers. So this is a type of voiding dysfunction. There's not a disease per se, it's a behavioral issue that causes issues. So if the child doesn't use the restroom during school and they try to distract themselves whenever they feel the urge rather than going to the restroom, they're going to end up having more frequency because you can only hold the urine for so long. Underactive bladder is having to raise your intra-abdominal pressure to initiate, maintain, or complete voiding associated with a weak urine stream. That would typically be caused by a neurologic issue. Dysfunctional voiding is it's based on a urodynamic finding where the child actually is contracting the sphincter or the pelvic floor when they void. This is not uncommon in children and adults, and it can happen for a variety of reasons, but they're basically not relaxing and getting into that parasympathetic state when they void, which obviously makes it more difficult to do an activity that is supposed to be parasympathetic. Stress incontinence is leaking small amounts of urine with increased intra-abdominal pressure, like sneezing, coughing, jumping. Vaginal reflux is when urine collects in the vagina after voiding, and then it will leak when the child stands. They won't have any other associated symptoms if this is their diagnosis. So basically when it's related to toileting position, and the urine will flow into the vagina in addition to flowing out into the toilet, but some of it will be trapped and will leak later. Giggle incontinence is leaking during or immediately after laughing. Otherwise, totally normal bladder function would be expected. Extraordinary daytime only frequency. This is a frequent need to void in the daytime only with very small voiding volumes, less than 50% of the estimated bladder capacity, which in children is their age plus 2 in ounces. So 3-year-old would have a 5-ounce bladder capacity expected. They shouldn't have incontinence or nocturia because this is a daytime issue. You do want to exclude polydipsia, diabetes mellitus, nephrogenic diabetes insipidus, UTI, viral syndromes. This is often self-limited. Enuresis, this is defined as incontinence during sleep in a child older than 5. Primary means they've never been dry for at least 6 months, so they never stopped wetting the bed. Secondary means that they were dry for at least 6 months and they've started wetting the bed again. This can be caused by a variety of factors. Polyuria might cause it. It certainly causes nocturia. The maturity of vasopressin release is thought to be a factor here. And this is just thought to be something that people develop at different ages so that they're able to control urine production at night. It's also similarly pregnant women make less vasopressin, elderly people make less. And so that's why nocturia is more common in those situations. Arousal disorders are very common with enuresis. You can ask these parents if the child's hard to wake up, and the vast majority will say, I can drag them through the house and they won't wake up. It's sometimes associated with obstructive sleep apnea, and it may be associated with nocturnal detrusor overactivity, which would cause less of a smaller bladder capacity at nighttime. It's twice as common in boys. It's very common. Up to 20% of children ages 4 to 6 have it to some degree. So, I mean, 1 in 5 children. And it resolves at varying ages. So that percentage will slowly decline as they age. Is the older a child gets they still have enuresis, they're more likely to have other lower urinary tract symptoms like daytime frequency. And it's extremely common to have at least one family member or siblings. Some studies have shown that enuresis is much more likely if both parents are affected, and it's thought to be autosomal dominant inheritance. And interestingly, the age of resolution is often quite similar across generations. So if they had an uncle who wet the bed till he was 13, that's pretty predictive that child will stop wetting the bed when they're 13. Comorbidities. So UTI, this can be the chicken or the egg. So the UTI may be happening because they have some underlying anatomical problem that's also causing voiding dysfunction. Or their voiding dysfunction may cause UTIs. So constipation and poor emptying are going to make someone more prone to UTIs, even if the constipation and poor emptying are related to their diet and behaviors. Vesicoureteral reflux primary is when the ureter doesn't tunnel appropriately in the bladder, and so that valve mechanism doesn't function properly. Secondary is when a child has severe voiding dysfunction and the bladder is staying full too much, and it creates a pop off and the urine refluxes back up to the bladder. Primary VUR is what you would most likely see. Secondary is usually in children who have issues like spina bifida. And the neuropsychiatric associations, up to 1/3 of children with a neuropsychiatric diagnosis also have bedwetting. Up to 40% have daytime urinary incontinence, and up to half have been shown to have fecal incontinence in some studies. The most common neuropsychiatric disorder or diagnosis that's associated with voiding dysfunction is actually ADHD. Oppositional defiant disorder is also associated with it. Anxiety and depression are associated with voiding dysfunction. And interestingly, sometimes when you treat the underlying condition, like treat ADHD or treat anxiety, the bowel and bladder dysfunction will improve. And some studies have suggested that similar brain regions control both, but we definitely don't understand this very well yet. And then bowel dysfunction, constipation is extremely common. And part of it's because of the shared physiologic control of the bowel and the bladder. Part of it's because if you're consuming a food or beverage that's irritating, it's likely to irritate both your bowel and your bladder. And constipation can also cause voiding dysfunction because that pressure from the retained stool keeps the bladder from functioning properly. So if I do a cystoscopy on someone who's constipated, I will see a bulge in their bladder from their distended rectum. And there's no way the bladder can store properly if it can't distend completely because of this external pressure. Treating constipation often resolves quite a bit of voiding dysfunction, and sometimes that resolves recurrent UTIs in children who are experiencing that. And then finally, neurologic, you certainly need to be considering things like spina bifida occulta, spinal cord injuries, tethered spinal cord. This is why you're always looking at the lower back and sacrum. If you have any suspicion that they might have an issue there, then you would want to order a spinal MRI, or they could see urology for urodynamics. And then neurologic disorders like transverse myelitis and multiple sclerosis can also cause bowel and bladder dysfunction. So these would certainly be considered if they're having other symptoms of transverse myelitis or multiple sclerosis and other systems like muscle weakness. So treatment. So obviously, if you make a diagnosis like a UTI or determine that a child has an anatomic abnormality, you'll treat those appropriately. But whenever you determine that it's a voiding dysfunctional issue that's not related to another comorbidity, the first step is to help parents understand it's rarely behavioral. This is especially appropriate in enuresis, because sometimes parents do think it's a behavioral thing and that they need to potty train the child or something like that. But if you can explain to them that it's an issue with ADH production at night, with an arousal disorder, that it's hereditary, that it's also seen in pregnancy and elderly people because of the same underlying reasons that we believe they have. This helps parents understand that it's not a behavioral problem that they need to train their children out of. I strongly discourage punishment for bowel and bladder issues because it's pretty rare that a child would be doing this intentionally, and because most children hate this too. But it's also counterproductive because, as I mentioned earlier, voiding and normal bowel function are parasympathetic activities. And if somebody's scared, if they're rushed, if they're having some sort of anxiety around things, they're not going to be able to relax and allow emptying to occur, which is a huge setup for voiding dysfunction. Instead, I encourage that they make it as simple as possible to manage accidents and give the child a fair amount of responsibility, not as a punishment, but just this is a problem we're all going to deal with, and here's how you can help. So, for example, putting some sort of liner on their bed so the mattress doesn't get wet, having an extra set of sheets available, teaching the child if they do wake up with a wet bed, how to put the sheets in the washing machine and, put a new sheet on their bed and go back to sleep without having to wake everybody up. And then also just educating children, because helping them understand the bladder fills, even if you don't feel like you need to go yet, you might be able to go. There may be urine in your bladder, and if you would empty it like before you get in the car, you're much less likely to suddenly need to go when you're in the car, and we may not be able to stop in time. And then helping them associate foods and fluids with urgency. So I had one of my children who, if she drank lemonade and then we got in the car, she was going to have an accident because she would have that urge and she could not wait. I told her if she wanted to drink lemonade, she needed to drink it at home when we could readily get to a restroom, and to avoid it if we were about to get in the car. And she was able to understand that, and eventually has outgrown that sensitivity, but it was an important learning experience for her. And then also educating them about normal bowel movement. So using the Bristol stool scales to show them, and reminding them that it's something they need to take time to do every day, and reminding them what's abnormal and what they need to tell their parents about. So urotherapy, there's a few things that we can do. One of them is timed voiding, which is basically going to the restroom at regular times, whether you feel like you need to go or not. This is very practical in a school setting, for example, when you have breaks at certain times, and that's when you should go empty your bladder to minimize disruptions. There are watches and alarms that you can buy for children that will have a vibratory alert so that it's not disrupting the class, to remind them that they need to go empty their bladder. This is also good for children who just don't have normal sensation and realize they need to go. And then working with schools, if I had a child with voiding dysfunction, I would usually write a prescription. This was back in the days when we had prescription pads, and ask them, if the child says he or she needs to use the restroom, please let them go. Please encourage them to go during regular breaks. But if they need to go during class, let them go. It's not good for them to be holding it. And then bedwetting alarms. So there's several available. And they have mixed efficacy. I've had some people tell me that these really helped with enuresis. I've had others say that it wouldn't wake their kid up because their kid is in such deep sleep. But it's an option for families to try that might help if it's something that they can afford. And you can just go to there's a place called Bedwetting Store online where you can buy tools like this. And then many other things you can do, like double voiding is really good for people that don't empty well. They urinate, empty their bladder, give it 5 minutes, and then go again. Toileting position and awareness is really important, especially for things like vaginal voiding or incomplete emptying. So if a child is in the physiologic position for voiding is squatting, which we don't do very much in our society. But the smaller the child is, the more sitting on a toilet is not a good functional position for them to empty. So they may need to be taught that they need to move around on the toilet, that maybe they do need to still use stools at home or small potties at home, but just paying attention to that. Like, how is this position affecting my ability to empty my bladder? Relaxation and deep breathing to help them get into that parasympathetic state can really help. Voiding diaries, as I mentioned, paying attention to bowel function, and then you can refer children for specialized care like biofeedback at pediatric clinics. There are physical therapists trained in pelvic floor muscle therapy who can help in non-invasive ways. There's a variety of, neuromodulation can be an option for certain conditions. So this is just an example of some of the biofeedback games. So on the top left here is a normal, or a picture of a just a standard flow rate monitor, but they can gamify this and teach children how to control their sphincter relaxation, how to, properly use their bladder to empty. These types of things are available typically at larger academic centers. Medications, most are off-label for pediatric use. There are several that are FDA approved for overactive bladder, usually for children over 2 or 3 years old. These I would certainly use very sparingly because they tend to have a lot of side effects with constipation, which can be counterproductive. Bladder neck dysfunction might be treatable with alpha blockers, but this is a diagnosis you would really make on urodynamics. So not something you would routinely just want to prescribe based on symptoms. Nocturnal enuresis, desmopressin is an option, and I'll speak more about that in a moment, and imipramine. And then SSRIs, you would not use an SSRI to treat voiding dysfunction, but if they have a psychologic condition that's an indication for an SSRI and you treat them, it has been shown to sometimes help with urinary symptoms. So red flags, I'll skip the typing in the chat bit, but any child who's had febrile UTIs, that is a red flag. They need to see a urologist. Secondary incontinence or enuresis is more concerning than primary. It indicates that something has occurred to disrupt their voiding or stooling patterns. And it may be trauma, it may be an anatomic issue, it may be some other illness. Never being able to potty train at all is a concern. This could represent a congenital issue that wasn't recognized when they were in diapers, such as an ectopic ureter. And overflow or continuous incontinence, as I mentioned on the next page there. Any physical exam abnormalities that you see. So if you see a sacral dimple, if you see meatal stenosis, those are signs that there may be an anatomic cause of the symptoms they're having. Any evidence of sexual abuse, of course, is a red flag on history or physical. Any history of congenital malformations, like I'm sure most of you know that ear malformations can be associated with kidney malformations, so that could be a sign that there may be something going on. Any genitourinary surgery, including routine circumcision, can cause side effects that later affect voiding. Any history of spinal cord issues. And fecal incontinence is also a red flag that requires referral but to GI. So let's go back to the cases briefly. So our 6-year-old girl having accidents at school. History is critical here. I mean, accidents at school tells us nothing. We need to find out all the details of what exactly is happening here. So we ask her a bunch of questions. There's no red flags at all. No history of UTIs. She has a totally normal exam. And interestingly, she had no problems before school started. What's happening is she's coming home with wet panties. At school, she's rushed to go to the bathroom. The toilets are just normal adult-sized toilets. She says she has accidents right after she pees. And at home, she uses a squatty potty to elevate her feet. So that's the difference there. She started going to school and doesn't have this adaptive tool that she grew up with at home and still uses. So this is a pretty classic case of vaginal voiding. And you would never do urodynamics for vaginal voiding, but this is what is happening here. This is an image from a video urodynamic. So there's a distended bladder with contrast. And this is the voiding phase. So you can see urine coming out through the urethra and then refluxing back up into the vagina. So when this child, they're probably lying down in this image. When they stand up, there's no sphincter here. So this is just going to leak out. It'll be enough to wet her clothes, but it's not going to be like as if she had lost her full bladder. And that's very typical for vaginal voiding. So you would want to teach voiding techniques. A lot of times the problems that we see are the little girl will just pull their pants just right down to the top of their thighs and sit on the big toilet and their feet are hanging. And that's kind of puts them in a position where the urine's going to go into the vagina by gravity. So you can elevate the feet, you can use smaller toilets, or little things like baby Bjorn potties, or you can tell the child to completely take one leg out of their clothing, and then they need to separate their legs whenever they urinate. And even sitting backwards on the toilet, that's common advice that I saw a lot back in my training, because that forces the urine to come out and not get trapped in the vagina. So the second case, 11-year-old boy, bedwetting at least 4 nights a week. He's never gone more than 2 weeks without bedwetting, so this is primary nocturnal enuresis. He used to wet the bed every night, but over the past 3 years, it's decreased to about 4 nights a week. His father wet the bed until he was 13. No history of UTIs and no genitourinary history other than a neonatal circumcision. So on physical exam, you actually see that his meatus looks more like this one. So this is an example. This is a penis with the foreskin intact. So you can see the difference in how the glans appears, because when someone is circumcised, it gets keratinized, and that can cause narrowing of the meatus. And it may be like this, but it also may be really small, like a pinpoint appearance. I've seen that quite often. And so there was actually a very large study published from Denmark, where they have such great population-based registries. So they had one group of 4 million males and one of 810,000 plus, and the hazard ratio for meatal stenosis like this it's 26 times more likely in circumcised boys. And one of my old urology textbooks said that it's pretty much exclusively a post-circumcision phenomenon. It's very common, and it does cause voiding dysfunction. So you see this, so you ask the child more questions like, how's your urine stream? Because you didn't ask him that before. And he does admit it sprays some, and he sometimes has to wipe the toilet seat after he goes, which is normal because this narrowing here would interfere with the normal stream flow. So you refer him to urology, and we often can do in-office meatotomy. So we would just numb this up with Imla cream and then inject lidocaine and snip the meatus to open it up. And it usually remains patent just from voiding. We can also do meatoplasty, where we put a couple of sutures in to help keep that open. That's a very effective procedure. So the child has that. His spraying has improved, but he does still have enuresis, and that's expected. Meatal stenosis does not cause enuresis. It's not the cause of primary nocturnal enuresis at all. So for that, it's really going to be about anticipatory guidance. He is improving as expected. So his father wet the bed till 13. He's gone from wetting every night to only wetting 4 times a week, which is understandably bothersome, but it is better. So you would reassure them that this is improving. We expect it to continue to improve. Probably around age 13 will be when this stops. And so you want to make it easier to manage accidents, as I discussed, restrict fluids at night, try alarms if they wish to, being sure to empty the bladder before bed. But this is an 11-year-old. And so this bedwetting could be causing social issues for him. So you would want to offer desmopressin. But desmopressin can be really dangerous. So it's got a warning on it for hyponatremia, fluid restriction, seizures. So basically, it inhibits, it prevents your body from making urine. And so if you drink fluids, you are going to become hyponatremic. So there on the label, the packaging label, it says you cannot drink any fluids for an hour before you take it or 8 hours after you take it. If a child does drink and they become hyponatremic, they can have seizures. So you must give the family and the child these instructions very clearly and explain to them why this is so important. But then you can figure out a dose that works for them. And the nasal spray and the tablets both can be 1 to 3 times. So I always start with 1, have them try it for 3 days. If it's not effective, go up to 2. If that's not effective after 3 days, go up to 3. We want to determine the lowest possible effective dose. But then once we know, okay, if I take 2 desmopressin tablets, I won't wet the bed, then we don't use it every single day. We use it whenever the child's going to summer camp or going to be in some social situation where bedwetting would be more of a problem because of the risk of seizures from hyponatremia. And also because over time this is going to get better, but if they're just taking desmopressin every day, they're not going to know if it's because they've outgrown this or because because of the desmopressin. So they might be taking it unnecessarily if they do that. So that's it. Sorry again for the power outage issues, but I'm glad we got through it on time, and I'm happy to take any questions.
Dr. Carmack, thank you so much for your great presentation. I will have you stop your share, and we do have some great questions and wanted to encourage people to continue submitting their questions as well. And then Dr. Carmack, you can also turn your video on. We can see if
Okay.
that'll work. And if not, we'll have you turn it off.
Yes.
Great. So just wanted to start off with you had said something about urinalysis and urine culture. If the UA is negative for leukocytes or negative entirely, but the culture is positive, should you treat?
Yes. So treatment of UTI should completely depend on the culture. And the standard guideline that we go by is greater than 100,000 colony forming units per milliliter growing on the urinalysis. And ideally, you're treating based on culture results. If you have a person who you can't wait for the culture to come back and you strongly suspect UTI, you can start treatment, but you still need to obtain a culture first and then adjust the treatment accordingly based on the culture.
Thank you. Is there a role for pelvic floor therapy, especially if there's constipation, maybe in older children and teens?
There is. It's more common to use biofeedback because you can do that with attaching external electrodes. So in adults, when we do pelvic floor therapy, it can be invasive because you get a better diagnosis if you're able to do a rectal exam or a vaginal exam and identify which muscles are dysfunctional and strengthen those. But there are definitely physical therapists who can do pelvic floor muscle therapy without being invasive. So there is a role for it.
Thank you.
Yeah.
How long should they have been dry before calling recurrence of enuresis secondary?
6 months. That's the official definition. Yeah.
Thank you.
Mm-hmm.
How much effort would you put into getting a family that cannot afford a bedwetting alarm?
Mm-hmm. Not a lot because they work very sporadically. So I've definitely seen families in whom they work, but that when the child, you can't wake them up, they're probably not going to wake up to a bedwetting alarm either. I've had a lot of families tell me that the alarm wakes up the rest of the family and not the child. So it's and they at least I haven't checked the prices lately, but they're typically were around $100. So for some people, that's not a big deal and it's worth a try. If it works, it was worth the $100. But for other people, that's a huge deal and not worth the hassle. It'd be easier just to manage accidents.
Great. Any more recommendations for children who can't seem to wake up at night to urinate?
Mm-hmm. The best thing is making sure that it's genuinely primary nocturnal enuresis and that there is an expectation that they're going to outgrow this. And again, that's based on history, on some level of improvement over time with age. It's based on family history, and it's based on them never having been completely dry at night and not having any, having a normal urinalysis, having a normal exam. So if everything else is normal and it really seems like primary nocturnal enuresis, anticipatory guidance is the best, and like putting a absorbent pad under the sheets on the bed, wearing diapers if the child doesn't mind that. Some children don't mind that. Some feel very awful if they have to wear a diaper when they're 10 years old. But it can make things a lot easier. Having extra sheets readily available for the child to use, things like that, to make it easier to deal with the accidents, knowing that they're going to get better and being patient until that happens.
Thank you.
Mm-hmm.
Suggestions for toilet training for children with developmental delay or autism?
That's a tough one, and I'm definitely not an expert on that. I would probably honestly have to defer more to the behavioral experts about it. Generally, it's very effective to raise awareness in children. So letting them experience, making voiding easy for them, talking to them about it, pointing out, like having a baby drawer and potty right there in the living room so that if they feel like they need to go potty, they can go right there. Anything that helps. If you just throw a child in a diaper and just change their diapers every couple hours and they never develop this awareness, it's going to delay the ability to potty train.
Thank you. Any role for cranberry juice for UTI prevention or treatment? A lot of patients like to try home remedies.
Yeah, cranberry juice can help for prevention. It's not recommended for treatment. But it has been shown in a few studies to be effective for prevention. The biggest challenges are the juice itself is often fortified with sugar, which obviously we don't want to be encouraging anyone to drink sugar. And then it also can cause a lot of GI distress. So if that's an issue with the child, with the person, then they're not going to like it. The tablets work, but the tablets that have been in studies work, and we don't know. There's no mechanism for consistency among tablets that are purchased. I'm not saying they don't work. It's just very challenging to make a recommendation, or if it doesn't work, to know whether it's because cranberry is not going to work for this person, or whether it's the tablets they got that are not of the quality that we would want.
Thank you. How long is it appropriate to use desmopressin?
So it's, as far as I know, long term, there's not an additive harm that I'm aware of. The issue with hyponatremia is short term. So you can use it, if some children continue to have bedwetting until they're 18 years old. And so it's certainly appropriate to use it in a 16-year-old if she's going off to be a camp counselor or something, and needs that help. But I personally don't feel comfortable having someone take it daily. I think it's not worth the danger. I think that it's only worth it if they're in a social situation that they really want to avoid having an accident.
Thank you. Could non-obstructing stones in the kidney pelvis cause urinary symptoms?
Typically, no. If the stone's up inside the kidney, it's pretty rare to even have local symptoms. So you would see blood in the urine sometimes, and it definitely may be associated with UTIs. But it shouldn't cause lower urinary tract symptoms, unless the stone's trying to pass. I mean, sometimes a small stone will pass and not cause a lot of pain, but it'll, when it's at the part of the ureter that's traversing the bladder, it can cause a lot of bladder symptoms, irritated voiding, like frequency, urgency. But if it's up in the renal pelvis, that would not be expected to cause bladder symptoms.
Thank you. Do you recommend waking the child after falling asleep to void?
So I don't know how well that works. I think it works for some children. It definitely does not work for all children. I've seen a lot of families who've tried this and very mixed results. And so I wouldn't be opposed to trying it, but if everybody hates doing it and they're still having accidents later, then it's not worth persisting in that.
Thank you.
Mhm.
I thought there were some recommendations to treat for a UTI with typical symptoms, even with a lower colony count than 100,000. Would this only be for adults, or would you not recommend this at all?
Yeah, that's a big judgment call. There are some studies that suggest that lower colony counts can be can be diagnostic for UTIs. The standard has been 100,000 in children, but certainly if I had a child who had classic UTI symptoms and they had 60,000, I would treat them.
Great, thank you. And do you have recommendations for educational resources for families with language barriers? I like giving handouts to take home for families to read, but it has been harder now that I see primarily non-English speaking immigrants.
Yeah, the clinic where I volunteer now is adults only, so I'm not familiar with child resources, but I do the same. A large proportion of our population speaks Spanish only, and I actually have a folder on my desktop with the handouts for common bladder irritants and for Kegel exercises, and a few other general things like what is a spermatocele that I've found online in Spanish. And that when I find them, I save them, and then I reuse those over and over. I have them available in English too, but I need them in Spanish more frequently. I do believe that Bedwetting Store has a lot of resources. I don't know if they have them translated or not. And the AUA has a patient advocacy group as well that I do believe they also have Spanish resources.
Great, thank you. So Adrienne, if you happen to have any links later on to some of at least the Spanish
Sure.
language materials, that would be great, and we could share that with
Yeah.
everybody.
Yeah. Great.
Is there an age cutoff for obtaining a urine culture, even if the urine drip is normal?
No.
Mhm.
No, you'd want to attain a urine culture if they have symptoms of UTI, so acute symptoms, dysuria, lower pelvic pain, etc. Regardless of what the UA shows, or if they have a UA that suggests infection,
Mhm.
no matter what the age.
Okay. Up to date says to go by a UA result when deciding to get a culture of children older
Mhm.
than 2. but not if under 2. Were
Mhm.
saying not to go by UA results at all?
Yeah, and this, not if there's suspicion of infection based on their symptoms. And that's based on the newest guidelines on treatment of recurrent UTIs in women, from the AUA. And so maybe not translatable to children, but it's the best data that we have. And they have found that dysuria is a far better predictor of a positive urine culture than an abnormal UA. And so if your clinical suspicion of a UTI is very strong, then you want to get a urine culture, regardless of the UA.
Great, thank you.
Mhm.
So I wanted to thank Dr. Carmack so much for this great presentation, and also to Generations for requesting this talk today. Just as a reminder, MAVEN Project physician volunteers in over 65 specialties are waiting and willing to help you. You can submit an email consult. They'll do one-on-one video consults with you as clinicians. So if you scroll down and you have more urology questions, Dr. Carmack is available under the Pediatric Urology group, as well as Dr. Lieberman. And then also we have adult urology, and we have 5 urologists there. And feel free to skim through. If you don't have an account, please talk with your clinical lead, and she can reach out to MAVEN Project to connect you. Get your account connected. If you need a little mini training or a refresher on how to submit a consult, please also reach out to MAVEN Project, and we are happy to help you. A huge thank you to all the clinicians for all you do in giving good care to your patient, and continuing your skills and education. And I hope everybody has a great rest of their week. Take care, everybody.
Right. Thank you.